Good morning, one and all. From IAP technical team, Dr. Smarnika, welcome you all to our 19th webinar of IAP WC Goa, which is on colorectal cancer awareness. Since we all know that March is the colorectal cancer awareness month, we thought of doing this program. 30th March being the colorectal cancer awareness day, we thought of doing this program on a Sunday so that all can attend it. So today's program, we have our expert with us, Dr. Sanjay Deshmukh, who will be doing the talk. The moderator for the session is going to be Dr. Rashmi Pawar. Question and answer by Dr. Palasha and vote of thanks by Dr. Gauri. So without much delay, I would like to request Dr. Rashmi to please start with the session.
Good morning, everyone. The IAP Women's Cell Goa State team and myself, Dr. Rashmi Rao Pawar, extend a warm welcome to one and all for its 21st webinar on colorectal cancer awareness presented by Dr. Sanjay Deshmukh, who is one of the leading and renowned oncologists in our country. Dr. Deshmukh has completed his MBBS and MS in general surgery from Aurangabad at the Government Medical College. He went on to do his MCH in surgical oncology from Tata Memorial Center in Mumbai. He has completed his fellowship from the University of Maryland in USA. He is presently the director and head of department of surgical oncology, Grant Medical Foundation, Ruby Hall Clinic, Pune. In 2004, Dr. Deshmukh started the Breast Cancer Center in Pune for the first time. He is the founder member and director of the Association of Breast Surgeons of India. Dr. Deshmukh is the founder president of Pune Oncology Group and past president of Pune Surgical Society. He is the member of Association of Surgeons of India and a member of Indian Medical Association of India. Dr. Deshmukh has organized many conferences and presented many papers on various topics such as esophagus cancer, lymph node dissection in breast cancer, and esophagectomy. He established Indrayani Hospital and Cancer Research Center for the Poor and Underprivileged in 2003. It has treated over 10,000 cancer patients in 2020 itself. Facilities of surgery, radiotherapy, and chemotherapy are offered free for these patients. Welcome, Dr. Sanjay Deshmukh. Before we start, I would like to request everyone to put down their questions in the chat group, and we will attend to it afterwards. Over to you, Dr. Sanjay Deshmukh.
Hi, good morning. Am I audible to everyone? Am I audible?
Yes, doctor, yes. Please go ahead.
Yes. First and foremost, I must actually express my gratitude to you, Indian Association of Physiotherapists Women Cell, to give me this opportunity to speak to you. And see, today, since we are actually having a month of colorectal cancer, and we are just actually talking about the colorectal cancer. What I have decided is that I will actually try and cover colorectal cancer in general, complete colorectal cancer, try not to go in deeper into any. Am I audible properly?
Yes, doctor.
Hello? Yes,
yes
thank
doctor.
you. Yes, yes. So what I'll do is that I'll try and cover most of the points. And if any particular question, I'll go into the deep about that part of this. As you know, this is one of the very common cancer, third most common cancer in India, second most cancer in the Western world. After lung cancer, this is one of the very common cancer. Annually, more than 1.2 million cases are seen, more than 600,000 deaths are due to colorectal cancer. As you know, there is a lot of geographical variation, and there are definite some amount of familial colorectal cancers which are seen in the world. Uh, sorry. Uh, as we know, the incidence varies due to in between countries, suggesting a lot of environmental factors. The peak incidence probably is in the 7th decade of the life, and the ratio in male and female is almost equal. There is a little bit amount of perception by people that more males are having colon cancer, but it is not correct. They almost equal this. And lifestyle plays an important role in the etiology of this disease. As we know, anatomy of the colon, which starts at the end of the small appendix, is the start of the colon. It ascends up, which is called as ascending colon. Then there is a transverse colon, which runs transversely over the stomach. And then there is a descending colon, which descends from the spleen down to the pelvis. And then there is a S-shaped volvulus of the colon, which is sigmoid colon. And then it meets the rectum. So this is supplied by two main arteries, superior mesenteric artery and inferior mesenteric artery. And simultaneously, there are two veins which will take the blood back from the colon. Colon has mainly the main use of colon is mainly to absorb water from the fecal residue. So if you look at the cross section of the colon, what you'll see is the mucosa here, which is the innermost part. Then there is a submucosa. Then there is a circular muscle layer. Then there is a straight, which is longitudinal muscle layer. And then there is an outer layer, which is called as serosa. So mucosa, submucosa, circular muscle, longitudinal muscle, and a serosa. Just a few factors which actually increases incidence and few factors which decreases incidence. Factor increasing in incidence are high caloric diet, overcooked red meat, high red meat consumption, low residue diet, excess alcohol consumption, smoking, sedentary lifestyle, obesity, diabetes. And again, you can decrease it by high fiber diet, exercise, fresh fruit and vegetables, high calcium, high magnesium diet. So these are the this. There is something which is about the polyps. Polyps are the benign growth on the inner wall of the colon. Now, these polyps are fairly common over the people above the age of 50. And those polyps increase the risk of developing colorectal cancer. Colonic polyp is well known to cause colorectal cancer, and benign polyp depends on the many factors. There's number of polyp, histological types of the polyp, how it is villus type or a tubular type. You can see in the corner, there's a typical polyp which is seen. I'll come to the polyps as we go further. Uh, Obviously, there are other risk factors for colonic cancer, and very important is a personal medical history. Any lady or a person who has a history of cancer, particularly women, ovary, uterus, breast, will have an increased incidence of a colorectal cancer. The previous history of cancer is one of the predisposing factor, and family medical history, that if you have first degree relatives, two first degree relatives, or one first degree and two second degree relatives, will put you into higher risk of having colorectal cancer. I'll come to it later as we go further. These are the familial adenomatosis polyposis and HNPC syndrome. These are the main syndromes which are seen for the familial cancer. Now, just about the FAP. FAP is one of the very lethal kind of familial condition where there is a chance of 100% chance of developing colorectal cancer. And it should be diagnosed early, and they should undergo preventive surgery by the age of 20 so that this colonic cancer can be prevented in these. There is a mutation in the APC gene. This is adenomatous polyposis coli gene, which causes genetic test. And this testing is very easily available, and yearly screening for polyps is recommended in these people. Most of these people will require a preventive surgery. There's another syndrome which is called as HNPCC, hereditary non-polyposis colorectal cancer, also sometimes called as Lynch syndrome. It accounts to 5 to 10% of all colorectal cancer cases. See, FAP accounts to 1%, HNPCC accounts to 5 to 10%, and risk of colorectal cancer is 70 to 90%. Generally, these people are diagnosed with colon cancer at the average age of 45, and genetic testing for HNPCC is very easily available now. We can do that. So other risk factors for colon cancer are inflammatory bowel disease, ulcerative colitis, Crohn's, somebody who has undergone irradiation or is immunosuppressed. Then there is a risk of colonic cancer. Just a few things about the multiple polyps. When someone has diagnosed with a polyps, when there is extensive polyposis, is most likely FAP, familial adenomatosis polyposis. And if it is less than 10 polyps, then there is a Lynch syndrome, which is HNPCC, which is hereditary non-polyposis cancer syndrome. And in between is called as MAP. This is another disease, familial disease with a mute-associated polyposis, but it is similar. So just about the vaguely in a general population risk of colon cancer over lifetime risk, it is lifetime risk. It is a 5%. If personal history of colorectal or other neoplasia, risk increased to 15 to 20%. If there is an inflammatory bowel disease, there is a 15 to 40%. If there is a HNPCC mutation, then there is a 80%, and FAP is almost 100%. So just brief about that. What actually happens in that is that there is a very classical adenoma carcinoma sequence which occurs in most of the colon cancer, irrespective of it is familial or HNPCC or a normal mutation, and it will convert into hyperproliferative epithelium. This hyperproliferative epithelium will have a loss of DNA methylation and will go into the early adenoma. Early adenoma will have a mutation of a RAS gene, which is a KRAS gene, and that will make it to the intermediate adenoma. And then see, there is a multiple sequence, and last sequence of that is a loss of P53 gene. P53 gene is a protective gene which protects us from the cancer. And most of the cancers, you will see the loss of P53 gene, which turns into the carcinoma. Just a sequence where you can see normal epithelium followed by initiation, then DNA methylation, with the intermediate adenoma, then there is a late adenoma, then there is a malignant conversion. So this little bit more schematic here: normal epithelium, hyperproliferative epithelium, small adenoma, large adenoma, and loss of disease. So this is a colon cancer, which you can see. This was a patient which I operated probably 20 years back. I hope everyone can follow me, Rashmi.
Yes, doctor. Yes, doctor.
Yes, thank you. Thank you. If there's anything, please, you can stop me in between also. There's no problem. So just about this, how many cancers? Now, this is a typical colon structure where you'll see cecum has a 12%, 22%, colon, right colon has 12%. So you can see the right side will have around 42% if you include transverse colon on right side. 42% cancers are on right side and 58% cancers on the left side of the colon. So left-sided colonic cancers are more common compared to the right-sided. This just little about a pathology. There's either cauliflower big like a growth, or there is an ulcer-like growth, or there is an annular growth, and there is a mucus secreting. Then there is a grade, which is grade 1, grade 2, and grade 3. We see these reports very commonly by the patients, and these patients, these require tell you how the cancers look. Is a broader classification of that, and that tells you the grades. So common histology is adenocarcinoma. There are different types which are on the morphology, which you see onto the microscope, multiple types, and there are 4 grades: well, moderate, poor, or undifferentiated. Remember, the grades are not stages. Stages are colorectal cancer, which is 1, 2, 3, 4 stages, are dependent onto the staging by the invasion of the tumor. So these are generally, it's the commonest famous staging is Duke's classification. Also, there is a TNM classification. So Duke's classification: A is confined to mucosa, B is going to the muscle wall partially, B2 involves serosa, and C1 involves lymph nodes, C2 involves serosa and lymph nodes. So just I'll just come to it again. This is a schematic drawing where you can see A is going up only to the mucosa, B is going up to the serosa, C1 is going to this, but there are lymph nodes positive, and C2 is going up to the serosa and lymph nodes are positive. Just about this, probably you can understand this better here. A is this, B1 is this is C, this is C plus lymph nodes, this is C1, and this is D. So you can probably see that. This is a TNM staging where similar thing is there, but T1 is up to the mucosa, T2 reaches up to the muscle, and T3 reaches up to the serosa. T4 goes out of it, and N plus. So just how the stages are grouped, you can see this very well shown into this cartoon, where you can see stage 0, which is very small, which is called as in situ carcinoma. Then you have a stage 1, where there is up to the mucosa, and as further where it goes to the stage 4. Remember, the stage and grades are different. Prognosis depends on the stage of disease, and there are factors which are independent of stage, like grade of the tumor, venous invasion, lymphatic emboli, number of lymph nodes involved, and a distant metastasis. So just about the survival, this is can be also stage 1, 2, 3, 4, or A, B, C, D, like a Duke's classification. A is 90%, stage 2 will be 70%, and stage 4 will be 10% survival. Remember, even in stage 4, there is a 10% survival. Now, symptoms of the cancer, symptoms of colorectal cancer depend on which sided this cancer is. Right-sided cancer will have a right iliac fossa pain, like a appendicitis. A lot of patients were diagnosed as appendicitis long time. Anemia, sudden developing anemia in a middle-aged man, you have to see that this man possibly has a cancer, because they are otherwise very well off and they have no other problem, and there is only hemoglobin dropping. There is no reason to have a drop in hemoglobin below 10 in a male or female without any reason after 40. So there is a possibility of a colon cancer. The other factors again are very evident when there is a tarry stools passing passed by the patient with the or loss of weight, then very easily diagnosed. Left-sided cancer, there are very classical alteration bowel habits, constipation followed by diarrhea. Then there is constantly these patients will think that they have amoebiasis and keep on taking the amoebiasis tablets, and they feel that they are better off with those amoebiasis tablets. There's definite loss of weight, and there is a pain onto the abdominal pain onto the left side. On a rectal cancer, when there is a colorectal cancer, which is the lowest cancer, you can see there is a fresh bleeding very commonly. Patients will say that they have piles. One of the biggest mistake which people do is that when patients say that piles, they don't see them and don't do a proctoscopy or a digital rectal examination, which is very, very important. There is diarrhea, there is loss of weight, as patients will have a further symptoms and an increased stage of disease. When the mass becomes very big, there can be a tenesmus, which is incomplete sense of incomplete evacuation, followed by perineal pain also. So this is just a kind of a broad thing where I have shown you that right side, left side, and the rectum. So just to let you know some, and again, this is not uncommon. 10% patients present with directly as an emergency in the emergency ward. They have acute obstruction, they are in the perforation and the shock, there's a severe jaundice, there's anemia with syncope, or there is a severe cough due to metastasis or a bony pain due to metastasis. Investigations, the most important holy grail of the investigation is the first is that doctor has to do a digital rectal examination. So if a patient comes to you and his doctors has not examined him or her in a rectal examination has not been done, he has done an incomplete examination. Fecal occult blood test is done very routinely. It gives you sometimes can have a false positive in people who are having frequent meat eaters. But again, a test which tells you how something wrong there routine blood tests. Then electrolytes are important because most of these patients will have a diarrhea and a change in. And carcinoembryonic antigen is a tumor marker, which you should do in the initial stages. Then in imaging, all this imaging is mainly, few of them are ultrasound imaging, where there is a chest X-ray is a standard chest X-ray. Then there is ultrasound abdomen. Very minimal nowadays, people don't do it as routinely as previously used to do. But yes, it is one of the important investigation. Ultrasound abdomen, transrectal ultrasound, for some definitely with very good CT scan, you detect almost very small, even polyps also. And MRI and PET scan. PET scan has made revolution into oncology imaging, and further as good PET scans are coming, we are getting more and more better information about the disease. These are few endoscopy and colonoscopy, where you can see when you are in doubt, you have to have a biopsy. And it is done by the colonoscopy, where you can see the colonoscope will show the mass there, and that has to be biopsied. Remember, whatever it is, we have to have a histopathological diagnosis before proceeding. You cannot proceed for these long procedures without a diagnosis, that is a pathologist diagnosis. And after the diagnosis, there is a MDT, that is a multidisciplinary tumor board meeting, which generally comprises, we in our hospital, both the hospitals, we have a weekly these tumor boards, and nowadays they are more of web-based tumor board, and they will vary surgical oncologists, gastroenterologists, medical oncologists, radiation oncologists, pathologists. I proposed that I had proposed that we should have uh, most of the other people who are important also should be part of that, but somehow we are not been successful in that. But I always feel that physiotherapists should be part of initial part of treatment, so that when the patient goes on to the treatment, they know exactly what is happening to it, and then they can follow it as is required. uh, Surgery generally is planned most of the times, planned for the cure. In some cases, it is also planned for the palliation of an incurable cancer. Resection of the tumor with adequate margins and regional nodal clearance is generally performed. Again, preventive surgery is another completely different chapter, which I'll cover briefly. And a preoperative, we have to evaluation by physio, very important, because we have to tell our physiotherapist to exactly what you are going to do, what patient is going to have, how patient's general condition, what is the general physician wants, exactly what are the comorbidities, and what are the exercises which you want to start before the surgery. And the early training of exercises and consultation is most important. Again, bowel preparation, antibiotic prophylaxis, and DVT prophylaxis. I like to admit my patients a day prior, because completely at minimum 24 hours before, because otherwise these things are really missed in this era of basically insurance based surgeries. Most of the people do not want to uh, admit patients a day prior, but it is important that they should come back. Now, on a surgical procedure, we have three options. On a surgical, there's an open surgery, which is an age-old surgery for these patients. There is a very properly done now laparoscopic surgery, and third is a robotic surgery. Remember, all the surgeries are very similar. They have to give us the best result. Open surgery is being standardized for many years. Laparoscopy last 15, 20 years is now fairly well acquainted by most of the surgeons, and tumors which are not very bulky very easily can come out. These most of the patients undergo laparoscopic surgery, and this is quite easy. Almost most of the surgeons are trained. Robotic surgery again is better, very good. We have a robo in Ruby Hall. It is very good. Only thing is that it is costly. Almost there's a cost of a robo which adds to the procedure, and there's a just a little bit more time because of the learning curve of the robo. It is very good for everything to be done for the patients. Now, For right-sided growth, there's a right hemicolectomy. Transverse colon, it is transverse colectomy. Descending colon, which is a left-sided colon, left hemicolectomy. For sigmoid colon, it is sigmoidectomy or anterior dissection. For a rectum, which is the lowest part of the colon, there is a anterior dissection of rectum or a low anterior dissection or a abdominoperineal dissection, where you remove rectum completely and give a stoma onto the left side of abdomen. There's some mistake here, but T1, T2, and 0 patients, there is no chemotherapy. They don't require any treatment. For T3 patients in a rectal cancer will require adjuvant chemotherapy. And for patients who are T3 onwards in a rectal cancer, these patients will require neoadjuvant chemoradiotherapy, where we give injection 5-FU with radiotherapy. It is given before surgery, and that's why it is called as neoadjuvant. And whenever there is a disease, colonic disease, which is generally undergoes surgery before, and then adjuvant treatment, which is given, then there are multiple parameters where will decide patient should receive chemotherapy or not. Obviously, patients who have more than one node involved, there's the lymphovesicular invasion is there, there's a perineural invasion is there, poor differentiation is there, then they require chemotherapy. Just about adjuvant and neoadjuvant, because I keep on talking about it. Whatever is given after surgery is adjuvant. Whatever is given before surgery is called as neoadjuvant. These terms which keep on coming very commonly, and they are called as NACT. NACT is neoadjuvant chemotherapy, and NACT-RT means neoadjuvant chemotherapy and radiotherapy. It is now becoming a part of standard care. There are different chemotherapy regime. We should not go into it, but they are very common now, very commonly used. And then there is some amount about the liver metastasis. We consider that patient who has got a liver metastasis is probably has very advanced disease and will not survive. But we have to tell you here that 5% patients who have a limited liver disease will undergo surgery of metastatectomy with liver surgery, and followed by the other methods like radiofrequency ablation or TESS and TER. And one of the things which has come in recent last 2 years with a really a bang is a liver transplantation. When there is a isolated liver disease, it is still not really recommended, but there are people who are liver transplantation. So for rectum, around 22 years back, and then he had rectal disease, liver disease, and he underwent hepatectomy. And hepatectomy was done, this was also done around 16, 17 years back, and he is perfectly fine. So just one of the example that how these people do well. Then there are the targeted treatment like cetuximab, bevacizumab. Again, targeted treatment in colon cancer has not really stood up to their promise, but newer and newer drugs are coming, which probably give us better this. So there's some amount of prevention of colorectal cancer. We can have a primary prevention or we can have a secondary prevention. Primary prevention, we can buy a diet, supplements like vitamins and selenium, lifestyle, and medications. And secondaries are you can do a sigmoidoscopy, colonoscopy, and excision of polyp. And there is a trial about if you can do a polypectomy, will have a better this. It does not develop overnight. So 80% will have polyps less than 1 centimeter. And polyps more than 1 centimeter in size will have a 10% risk of developing cancer. So you can actually reduce almost 1/3 cancer by diagnosing them early and removing the polyp. And obviously, as we know, they are always a adenoma carcinoma sequence. So we can do a colonoscopy after the age of 50 and we'll have most of the patients completely prevented. This is a typical patients which is on a common preventive ultrasound, where we could see there's a small polyp on a sonography, very small polyp on sonography. You can see on a CT scan, the same polyp can be seen. On endoscopy, same polyps can be seen. This is again very long back. This is a 10-year back film which we have. So this is something which is very good. So there is also now has a virtual colonography, there is a sigmoidoscopy, double contrast enema, and these are the things which to prevent this. So take home message, more than one third deaths can be avoided by colonoscopy over the age of 50. Most colorectal cancers start as polyps and they don't give symptoms, and polypectomy can cure from potential colon cancer. This is one of the preventable cancer, common in both women and men. Newer methods has made treatments pain-free and more effective. Thank you.
Thank you, Dr. Sanjay.
Thank you.
That was a wonderful presentation, really informative.
Thanks a lot. Thanks.
We're grateful for your time. Right now, we'll be going on for the question answer session.
Yes.
And we have a few questions for you. Okay, the first question, doctor, is can patients exercise during treatment? If so, what kind is recommended and how often?
Most of the times it depends on the surgery, what surgery has been done. In a laparoscopic surgery, post surgery, patient is advised, or most of the surgeries, patients are advised to have exercise, which they can have a consultation between doctor and his physiotherapist, and can define what is the exercise which patient can have. Most of the times, what I tell my patients, all abdominal cancers should have respiratory exercises, very, very important. And they should have a walking. Walk is the most important exercise, which I advise for the first month. So simple exercises with their upper body exercises, followed by a walk. Most exercises which we say don't do it are straining. If there is a big surgical scar like open surgery, then we will say avoid lifting weights, avoid Indian toilets, basically, where they have to squat and give pressure for passing stools, or try and see that they don't have a chronic cough. And if there is a cough, it has to you have to give them some kind of medicine for that. Is that okay?
Yes, yes, doctor. Thank you so much. Can I request you to just stop screen share, please?
Okay, I'll just stop my screen share.
Yes.
Fine.
Thank you. Thank you. So next question, doctor. Is there a need for a special diet during the treatment or after treatment?
During treatment, actually, what we need is basically a soft diet, which is a less spicy diet, and we have to ask them to avoid raw salads, because most of the times people think that those are healthy, and then they have a lot of salads. So those they are not really able to digest very easily, and then they have loose motions. So green vegetables are fine when somebody who is otherwise normal. But for a post surgical patients, we should give them a cooked food, which is if you are giving them leafy vegetables, they should be cooked. That is what I advise generally. So try and give them a soft diet, which they can easily digest. That is what is more common.
Thank you, doctor. That was very informative, because salads, someone would think that, it's good for roughage and all that.
Yeah.
Yes. So let's move on. How do we know if the cancer has come back, and what are the symptoms that we should look out for?
For a long time, actually, what we used to do is that we used to evaluate these patients periodically. We used to tell them that to come every 6 months and ask them to do certain tests. Nowadays, what has been really been the standard of care is that they should be seen every 6 months periodically, but we are not really supposed to do extensive tests. What you must be seeing surrounding in most of the people who are, even doctors advise, because PET scan is known, like everyone knows that why PET scan is not done, and they will do a PET scan, but it is not recommended. It is not recommended. You are actually putting patients under this threat that they have to do PET scan, then there will be something in it. So when and how they should be followed? They should be followed for their basically weight, their routine blood tests. If there is any change in blood tests, then only, like suppose hemoglobin is dropped, his weight is dropped, or if there is certain kind of a finding, clinical finding, which tells you that uh, something should be advised, then only you are supposed to advise. But it is unfortunate that everyone asks them to do almost 2 monthly or 3 monthly PET scan. I don't think that detecting cancers early will make them free of cancers. So there is no proof on that. So we just make them suffer a lot. So what is this is a recommendation is that just a clinical examination and ask them what is wrong with them.
Thank you, doctor. You mentioned that left-sided colon cancer was more common. What could be the reason for that, doctor?
Mm, See, now this is a data of the world, right? So I assume, this is my assumption. I don't know. I don't have clear-cut scientific proof, but most of the Western population will have a very high colon cancer compared to Indian population, and they have a low residue diet, meat-based diet. So the bowel transit time, that is something called as, that is considered to be part of their reason for the cancer. So most of the times, like if you look at the Westerners, most of the times they do not really, they are all constipated. So whenever someone, a white man tells you such a fine day, so you mean to say that he probably has very good motions today. So so that just tells us that that is possibly the reason or the left-sided cancer. But again, this is just a very wild guess. I don't have any clear-cut information on that.
Yes, doctor. Really simple question. How quickly, as far as your research, does colon cancer grow? Is
It
there a set?
usually takes a long time, very long time. From cancer first detected to have a completely encircling cancer will take 18 months. So you have, say, cancer around 1 centimeter, and it goes all around the bowel wall to have occupy the bowel wall. Will take exactly 18 months, like almost 1.5 year, and that is a year which generally people waste. Actually, you have before that around 5 years. Like if everyone does a colonoscopy at the age of 50, now what has happened is that we have actually very slowly inching towards the Western kind of a incidence of colon cancer. We are not really up to them, but still, we are slowly, steadily going up. And that means that we have a lot of westernized lifestyle. We have a lot of non-veg diet in our diet. So that is increasing our risk of colon cancer. So we should, all of us should do a colonoscopy at the age of 50, which will give you a 10-year freedom from not having possibility of a colon cancer, which is very simple, very easy. There are very good colonoscope which will detect very small polyps. So we and our nearby close ones, we have to insist that they have to undergo colonoscopy at the age of 50. And you must be seeing these most of the news where US President George Bush underwent colonoscopy and had a syncopal attack. So that was because it is mandatory at them, mandatory in the Western population. We should probably, particularly urban population of India, should do a colonoscopy every 10 years.
Yes, doctor. We should increase awareness about this.
Yes, it's
Very
one of
true.
the most preventable cancers.
Yes. Thank you. In what conditions would colonoscopy be contraindicated?
See, someone who is on blood thinning agents, like somebody who has undergone some heart procedures and is on antiplatelet agents like clopidogrel, aspirin, ecosprin. So in those patients, actually, is not really contraindicated, relatively contraindicated, where you can advise them to stop that for a few days, 2-3 days, and then undergo colonoscopy. Otherwise, obviously, a general fitness or any procedure where you feel that this man should undergo a basic kind of is not well to undergo any procedure, then you can do his routine ECG just, but otherwise it is not really required. It's a outpatient procedure.
Right. Thank
And one of the thing which I will tell you, yeah, just one thing is that most of my colleagues now who are endoscopists, they do colonoscopy by giving certain amount of anesthesia. They say that most of the times people are scared of doing colonoscopy because of pain, and there's certain amount of some small sedation is given by anesthetist, standby anesthetist. It increases the cost of the whole procedure, but yes, it becomes less painful.
Right. Doctor, next question is, if someone has a family history, what are the precautionary measures that can be followed?
It is very large topic actually. There are, as I told you, there are two common things, which is FAP, which is familial adenomatosis polyposis, which is very common, and these kind of families will know that they have a colon cancer, and in that family people will have will know exactly what to do, because already there has been early deaths in the family. And in those, they have to undergo colectomy by the age of 15 to 20, complete
Doctor? Doctor, I'd like to interrupt you.
the
Sorry.
lower to see if any lower rectum. The HNPCC not be the early, they will have a stage of and you will see amongst all around us there will be lots. I'll just again try and connect it again. Okay, thank you. Yes, thank you. Okay. Am I audible?
Yes, doctor.
Okay, fine.
We didn't get the last. We didn't get the last answer. You want me to repeat it?
See, am I audible properly?
Yes, doctor. Go ahead.
Okay. The last HNPCC, and where you have my voice is breaking. Okay, am I audible properly?
Yes, doctor. Yes.
Just try. I'll try to again reconnect. Wait a minute. Is that better now?
Better now, doctor.
Better. Okay, fine. So one thing which I told you, familial FAP, and second thing. Hello. Yes. Hello. Hello.
Yes, doctor.
Yes, the second thing is HNPC. This is a hereditary non-polyposis colorectal cancer. This HNPCC is a little difficult to know when it comes. So in these kind of things where you have multiple relatives with the colon cancer, you should consult a genetic counselor. Genetic counselor will tell you risk of colon cancer, and then should do the test for HNPCC mutation, and then undergo early kind of evaluation for the colonoscopy.
Yes.
Colonoscopy.
Okay. Thank you, doctor. Our last question would be, is there any research done on vegetarians versus non-vegetarians on colorectal cancer?
As far as I know, no randomized trial. There is no trial where you have randomized, double randomized. Because see, here you will have require a trial almost more than 100,000 people to define that non-vegetarian diet induces colon cancer and vegetarians are not really suffering from it. So as far as I know, I don't think that there is a large population-based trial for this kind of thing.
Okay. Thank you, Doctor. That would be the end of the session. I would like Dr. Gauri to give the vote of thanks, please.
Hello, good day, everyone. This is Dr. Gauri Kamadwag. I'm grateful to get this opportunity today to present vote of thanks. First of all, I would extend sincere thanks to Dr. Sanjay Deshmukh for accepting our request to share his knowledge and expertise with us on this topic. It was indeed insightful session, Doctor, and we have received a very good information about colorectal cancer today. I hope we will be able to detect the signs early if we come across any patients and refer to professionals as early as possible. I would also like to thank all the participants of this webinar. Also, I would take this opportunity to congratulate our physiotherapy fraternity and IAP members who have worked hard to achieve a status of independent healthcare profession. I would thank IAP Central team to provide this platform to conduct the webinar and all the technical support for the same. And most importantly, I would thank all the IAP Women's Cell Goa team members for putting efforts to make this webinar a success. Thank you, everyone.
Thank you all. Thank you for giving us your time. Thank you, Doctor.
Bye. Thank you.